Good afternoon, everyone, and welcome to today's webinar, Opportunities to Increase Vaccine Compliance in the U.S., HPV and its Link to Cancer. My name is Kenesha Baldwin, and I am the Director of Educational Campaigns at the Prevent Cancer Foundation. Today's webinar is offered as part of the Foundation's Think About the Link campaign. Launched earlier this year to increase the public's awareness of the link between certain viruses and cancer, the campaign focuses on HPV, hepatitis B, and hepatitis C, as well as related cancers, in order to increase screening rates for all three viruses, vaccination rates for HPV and hepatitis B, and awareness of available treatment options for hepatitis B and hepatitis C. Please visit www.preventcancer.org. Think about the link for more information about our efforts. You should see the URL on your screen right now. So before we get started with this session, I'd like to go over a couple of items so you know how to participate in today's event. Right now, you're listening using your computer's speaker system by default, but if you prefer to join over the phone, you can just select telephone in the audio pane of the attendee interface, and then dial-in information will be displayed for you. Also, you do have the opportunity to submit text questions to today's presenters by typing your questions into the pane that says questions in the control panel. You can send in your questions at any time during the broadcast, and then we will address as many of them as possible at the conclusion of our third and final speaker during the Q&A session at the end of today's presentation. So thank you for that. And now for the reason you all are participating today, we'll go ahead and get started. Our first speaker is Dr. Loris Ramondetta. Sorry about that. Our first speaker is Dr. Loris Ramondetta. She is a professor of gynecologic oncology and reproductive medicine at the University of Texas MD Anderson Cancer Center. Dr. Ramondetta will discuss consequences of the tragic underuse of the HPV vaccine. Dr. Ramondetta, I am turning the screen over to you in 1 moment.
Thank you so much, Kenesha. Can you hear me okay?
Yes.
Great.
You can go ahead and get started.
Great. All right. Thank you all for joining us today on this very important topic. Today we'll be talking about the consequences of the tragic underuse of the HPV vaccine. As Kenesha said, I work for MD Anderson Cancer Center, and I spend my clinical time at the LBJ Hospital in part of Harris Health System. I don't appear to be able to move the slides yet, Kenesha. There we go. No, it's still, I think you're still moving it.
Okay. Let's try that again. It should be working.
There we go. I have no conflicts of interest. So what we'll do over the next few minutes is discuss the range of HPV-associated cancers, and we'll talk briefly about a cancer center's efforts to reduce HPV-related cancers. Recently, we saw the MMWR reports that showed that from 2008 to 2012, that the number of HPV-associated cancers climbed to nearly 39,000. There were 11,000, almost 12,000 cases of cervix cancer, and there were about 12,600 cases of oropharyngeal cancers in males and 5,000 anal cancers. 79% of these cancers, or 30,700, can be attributed to HPV infections. And 28,500 of these cancers are attributable to those HPV types that can be prevented with the 9-valent HPV vaccine. What's really important to know is that almost all people will be infected with at least one type of HPV at some point, and most of us will never know that we've been affected. It can occur with any intimate sexual contacts, and intercourse is not necessary for infection. There's an estimated 79 million Americans currently infected, and the HPV infection is most common in teens through their 20s. There are multiple different types of HPV infections or HPV subtypes. The majority of these are cutaneous infections, like the common wart, but a good percentage of them are in HPV subtypes that preferentially infect the mucosa. HPV high-risk types, HPV 16 and 18, are the most common, and they're responsible for cervical, anal genital, oropharyngeal cancers, as well as cancer precursors. And then the low-risk types, HPV 6 and 11, which can cause laryngeal papillomas on young children and genital warts, as well as low-grade cervical disease. The cancers that can be caused by HPV, and many people find this surprising, are vulvar, vaginal, cervical, which everyone knew, penile, which less people know, anal cancer, of which the majority are caused by HPV, and oropharyngeal cancers, which are specifically tonsils and the cancers in the back, tonsillar cancer and cancer in the back of the tongue. These are the fastest rising cancers related to HPV, and the majority of them are found in males. As I said, HPV 16 and 18 cause the majority of these lesions, and HPV 6 and 11 cause 90% of all genital warts and infant recurrent papules. The HPV virus infects the basal layer of the epidermis, and the genome of the virus incorporates itself into our genome and causes an uncontrolled expression of two oncogenes, E6 and E7. Those oncogenes bind with tumor suppressor genes and inactivate them. The HPV cancers, as I mentioned, are anal, cervix, oropharyngeal, penile, vaginal, and vulvar. And although the anal cancers are equally distributed between men and women, the oropharyngeal cancers seem to appear the majority of the time in men. This is a really important slide because so many people are worried about reducing the risk of whooping cough and meningitis through vaccinations, and we do pretty well at those, usually reaching about 70 to 80% of young children with those vaccines. Unfortunately, if you look at cancers related to these preventable diseases, the majority of the deaths occur in HPV-related cancers. Cervical cancer, specifically, has a defined avoidable etiology, and if caught early is curable. This is a really unique cancer situation. Unfortunately, Texas is one of the leading states in incident rates, and we still see over 4,000 deaths per year. The correlation between HPV and cervical cancer is higher than that between smoking and lung cancer. But what people don't realize is that we're experiencing an HPV epidemic in men. In fact, the national rates of HPV cancers in men are continuing to rise as the years go by more than 5% in tongue cancer, back of the tongue, oropharyngeal cancer in the tonsil, and anal cancers. And in fact, at MD Anderson, we see more new cancers related to oropharynx than to cervix cancer at this point. Oropharynx is a difficult word, and this graph should indicate where these cancers occur. So back where you get your strep test, back where somebody swabs the back of your throat, is actually where the oropharynx is, but it's too far back to see. And so there is no good screening test at this point, no approved or effective screening test for oropharyngeal cancers. And again, they occur in the tonsil and the base of the tongue. And like the pap smear, you can sample the small amount of cells that are exfoliated off of the cervix and detect precancerous lesions. You cannot do the same with the oropharynx. One, because it's too far back. We've all had strep tests where it makes you want to gag. We can't get any farther back than that. And the oropharynx cancers start in the base of the tonsils, the crypts of the tonsils, and are too hidden to find those cells. There is no known pre-invasive stage. There is no approved effective screening test, and unfortunately for these men, usually in the mid-50s, they detect the cancer incidentally while they are shaving and notice a lump in their neck, which is where it has already spread to lymph nodes. Anal cancer can occur with women who've had a history of high-grade cervical cancer, vulvar cancer, or vaginal cancer. It can also occur in HIV-positive men and women, men who have sex with men, and people who are immunosuppressed because of organ transplants or long-term oral corticosteroid use, like for rheumatoid arthritis. So when should we vaccinate? I know people will go over this again in a few minutes, but just to stress that we want you all to walk out of this webinar knowing that preteens, both boys and girls, should finish their HPV vaccine series by the age 13. Unfortunately, we're doing a terrible job. In the United States, and hopefully we'll see some increased rate in the next few days when the teen survey data comes out, but in the next few days, the United States is only vaccinating 40% of its girls and only about 22% of its boys completely with the full series, when many countries in the rest of the world are far advanced. It's really my opinion that it's your job as a clinician, as a provider, as a community member to recommend a vaccine that is recommended by the American Academy of Pediatrics, the American College of Immunization Practice, and to be honest, it's the equivalent of not having your patients do other screening tests like mammograms or colonoscopies and then seeing them come back with cancer. At MD Anderson, we believe it's partially our role to raise awareness because we're the clinicians that are seeing the downstream effects of not vaccinating. And over the last few years, we've developed an HPV cancer moonshot, and part of that, 1/3 of it, is devoted to raising awareness about the need to vaccinate and improve screening options for those of low resources, and also to develop screening tests for oropharyngeal cancers. Our goal is to help reach healthy people goals, which is to get 80% vaccination rate by 2020. We also hope to improve the access to cervical cancer screening and to develop new screening paradigms for non-cervical HPV-related malignancies. We're working with the Department of Health and the Health and Human Services on legislation to increase vaccination rates or learning how to raise vaccination rates around Texas. We're doing an economic modeling project with the UT School of Public Health. We have completed the MD Anderson Texas HPV environmental scan with the help of many of you on the line, and you can see this and download it for free on the Texas Cancer Information website. And we've worked with 69 other NCI-designated cancer centers to develop an HPV consensus statement. That statement was signed by all of the total number of NCI-designated cancer centers around the state, and we wrote together that we are tragically underusing the HPV vaccine. We're working with many partners across the state on an information transfer demonstration project, and in blue you can see the areas where we have or will be traveling over the next year in order to meet with willing providers and provider groups to train all members of their staff, from their scheduler to their MAs and to their providers, in order to talk to them about recommendations on how to raise their vaccination rates. We're also working with our survivors of all cancers, cervix, head and neck, oropharyngeal specifically, and anal cancer, as well as the penile cancer survivors, to teach them how to be better advocates. And at this point in time, we've had over 70 people say that they're willing to learn how to be better advocates. We hope to make those survivors available to any of you who would like to have a survivor present at presentations around the state. We've launched a mass reach social marketing campaign, and this is the first time MD Anderson has connected an educational message to its marketing campaign. I'm having trouble advancing. There we go. We realized that our own clinicians and employees seem to have low education levels around the use and effectiveness of the vaccine. We launched a large campaign over the last year to improve the educational understanding of our employees, as well as a clinic for our children of our employees and our employees under the age of 26 eligible for the vaccine. We've had 3 clinics so far, and the third one had 22 patients, employees' children vaccinated. trying to advance just a little more. There we go. We've developed multiple materials for providers and the lay public, which are also all available on the Texas Cancer Information website. And although our magnet doesn't light up like some have in the past, we do have magnets that can be ordered for your specific clinic to help patients and family members recognize the need to come back to be fully protected against HPV-related infections. And with that, I'll stop. I believe we're taking questions at the end, or you can text them in, and I thank you for allowing us to bring this information to you.
Thank you, Dr. Ramondetta. Everyone, again, if you would like more information on what Dr. Ramondetta has spoken about, that's HPV Moonshot Team at mdanderson.org. Next, we will hear from Dr. Stanley Block. Dr. Block is a pediatrician in private practice and professor of clinical pediatrics at the University of Louisville and University of Kentucky. He will discuss how to become an HPV-9 champion. Dr. Block, I am turning the screen over to you. The screen is yours.
Is it over? All right. There we go. Thanks. My name is Stan Block, and I'm a general pediatrician in private practice in rural Kentucky. I've been in practice now over 34 years. I'm also heavily involved with research with the HPV vaccines. In fact, we're still doing part of the long-term follow-up of the HPV-9 vaccine for our teens and young adults. I've also been part of the research team for the last 15 years with both HPV-4 and HPV-2 and HPV-9. So I've been heavily involved with the papers, and you'll see some of those papers referenced here today. So how can we improve our HPV vaccination rates? Well, across the USA, only about 30% of all patients receive all 3 doses by age 17 for girls, and 60% get at least 1 dose by age 17. But in our practice, we have about a 70% rate for all 3 doses by age 17. So the question is, how do you do it, and how can we get there? So first thing you have to do is understand what you're trying to prevent and know it well. You have to understand the vaccine effectiveness, the importance of age, and the importance of the durability of the vaccine. You also need to be able to explain the real adverse events of the vaccine versus the internet gossip, and then implement and implement and implement in your office. Let's talk about these things. First of all, HPV-9, we're going to talk about exclusively HPV-9 because HPV-4 should not be used anymore, in my opinion. You don't want to cheat your patients the extra 20% coverage. So there are 5 cancers in females. We have proven that cervical, vaginal, vulvar, and anal cancers can be prevented. Oral cancers, we cannot say they can be prevented. We think they can. Scientifically, they should be, but you cannot, according to the FDA, say categorically this will be done. Secondly, there are 3 cancers in males. Number 1, as you heard earlier from Dr. Ramondetti, that the oral cancers are the biggest number for males. In fact, it's almost as great as cervical cancers. However, again, we think it should prevent it, but we can't say. So I always couch my statements that we should be able to probably prevent the oral cancers in both males and females, but you really don't have hard data suggesting that. We do have proven data on anal cancers, and there's enough data on penile cancers to say that it should work for that as well. Australian data also shows you this prevent a spread of infection with the 4 HPV strains, so we can also get some herd protection with these vaccines as well. Okay, now HPV, there we go, one back here, there we go. HPV-9 is a cancer prevention vaccine. We have the potential to prevent 28,500 cancer cases strictly related to the strains in the vaccine, both males and females. About 9,500 cervical cancers and 10,000 oral cancers. And male to female ratio is 4-to-1, so it's 8,000 to 2,000 oral cancers that we can prevent. And this is the ultimate reason we should probably vaccinate boys, but there are other good ones as well. Again, approximately a third of these patients will die. It depends on how advanced their cancer is and if they've invaded the lymph nodes. But all these patients will undergo surgery, chemotherapy, and a large number will go bankrupt financially because this is extremely costly. The other thing is we're preventing about 250,000 HPV CIN2-3s of the cancer, the precancer of the cervix. We're preventing about 500,000 of scary surgical CI1 cases. Once you get a pap smear that's a CN1, the patient is extremely worried and anxious. And they're concerned, are we going to get cancer? Is this going to develop into full-blown cancer or surgical cancers, precancers? Also, HPV-associated cancers across the USA. Unfortunately, Kentucky has the highest rate in the USA for these cancers. We're up to 14.7 per 100,000. And there are demographic reasons for this, but I won't go into that here. The HPV-9 vaccine is about 90 to 100% type-specific effective. Let's show you some data. This is a clinical trial we did recently comparing HPV-9 versus HPV-4, and these data are concerning the 5 extra strains in HPV-9. So, again, this is not HPV-16 or 18. This is strictly the other 5 you see down at the bottom here, which cause about 10 to 25% of HPV cancers. But you can see the reduction of vaccine with the vaccine, CIN2s, 3s, VINs, and VANs 2, 3, is 97% for all CINs. VINs and VANs, it's 97%, and for persistent infection, it's about 96%. So this is a highly efficacious vaccine. Now, if you look at an important thing that's not been examined very well until this study, that we show that if you compare the extra strains, the 5 extra strains, what's the reduction you get with HPV-9 versus HPV-4 for those extra 5 strains? Again, this is not looking at 16 and 18. For biopsies, you get a 97% reduction. For genital biopsies, it's 91%, and for cervical biopsies, 97%, and for LEAP therapy, 87% reduction. So we're having major impact upon surgical, pre-surgical, and LEAP therapies on all these young women. Okay. Now, in essence, we know that these 7 types, which cause about 80 to 90% of all HPV cancers, we are going to be able to prevent 98% of the bad ones of cervicals, CIN2s and CIN3s, about 100% effective for vaginal and vulvar precancers, 80% for anal precancers, and this is in males, the data is, and 100% for venereal condyloma for females, and 91% for venereal condyloma in males. So highly effective vaccine. And let's look at some real-world data. So how does this thing work out in the real world? And that's always a question. So if you look at these data, here's CIN3 over here, and this is the most recent cohort from Denmark. And if you look, the more current cohorts have a much higher vaccination rate, and therefore we're seeing major reductions in CIN3 and CIN2 among these cohorts. So you get a reduction of 73 to 80% in this real-world setting in Denmark. And there's other data out there in our publication from Dr. Garland and myself in Clinical Infectious Diseases 2016, just published last month. So I suggest you get a look at this article because it's extremely well done, and it's about the HPV-4 vaccine, not HPV-9. But it's very valuable data for you to look at to know for your patients. So annually, 80% of women are current with their pap tests. So the pap tests are good, but we're missing a large percentage of the population. There are also no screenings whatsoever for the other 4 cancers, as you heard earlier. It spares, this vaccine will spare 1/4 of a million people from undergoing surgical therapy for CIN2 and 3, and it spares about 500,000 women from undergoing further PAPs, biopsies, and terror and expense for CIN1. So it's huge implications for the female population. Okay, this is my rules of 3. 3 doses by 13 is the goal. Why emphasize children under 13? Well, number 1, sexual exposure. If you're not exposed, you can't have HPV. So less than 2% by age 13 have sexual exposure. However, by 15, you got 25% exposure. As you heard earlier, the younger you are, the younger girls in these teen populations tend to get infected real rapidly, once they hit 15 through 18. Also, young adults do as well. The other thing about this under 13 is that 2 times the antibody titers for older adolescents. So you get a higher titer when you give it to the younger girls. This is the 10 to 15-year-old population. Furthermore, if you compare 9 to 12-year-olds versus 13 to 15-year-olds, you get 2 times higher antibody levels at 10 years, also at 8 years as well. So in essence, you get better levels the younger you are. In essence, also, you need to know that we have established durability for 8 years now. So the vaccine's lasting 8 years, and you'll see our publication in the next probably 6 months. It looks like we'll have that shortly. That's going to last 10 years for sure. Also, to give the vaccine to young girls, it's much easier to give it to kids under age 13. 9 to 12-year-olds are not going to fight their parents. You're not going to have to argue with them. Generally, they'll say yes, ma'am, to mom or to dad, or yes, sir, to dad, when they are asked to get their vaccine. Whereas a 15-year-old, she says, I don't want the vaccine, she's not going to get that vaccine. You cannot make her. It's not going to happen. Also, this needle phobia is easier to persuade them as well. So again, after age 14, I made a tremendous amount of resistance. When a girl says or a boy says, I don't want that vaccine, it's not going to happen. And again, this is not a safety issue to give 3 shots so much. So a lot of us at age 11 or 12 are given the Menactor vaccine, the Tdap vaccine, and also the HPV vaccine. We published data showing that it's safe and effective to do so. Antibody levels are not diminished at all. All right. The other thing about before 13 is the adverse event profile. Girls under 13 don't get blood clots. They don't get these autoimmune things, these thyroid issues, these neurological issues. Also, you have no pregnancy issues, no congenital defect issues, no sterility gossip that's on the internet everywhere. So you avoid these very messy internet issues and innuendos and false claims against this vaccine. So that's why when you give it under 13, you don't have to deal with all this background noise that naturally occurs in girls 14 and above. All these autoimmune things, blood clots, etc. So that's huge. It makes my job so much easier. Okay, also, this vaccine has no association with amenorrhea or sterility as you see on the internet off and on all day long. In fact, in the clinical trials, both of them that we performed with HPV-4 and HPV-2, 13% of young women became pregnant in the clinical trials, unfortunately, which kind of messed up our data somewhat as far as looking at the continuations. Also, rates of congenital defects are not increased with this vaccine. That's been studied, and there's no scientific plausibility for this either problem. Okay. HPV-9 does not cause infection. It does not cause cancer. You have to mention that to your patients because they're thinking this thing can do things to them, cause the actual infection. Also, you want to give it before they're infected, obviously. And the vaccine will work much better if you are able to get all 7 or all 9 strains covered with the vaccine. And again, we can't predict whose cancer gene will get turned on because this virus goes dormant, and then we don't know who's going to wind up with the cancer later on of the cervix or vagina, or etc. Okay, you also don't have to worry about HPV status. So if you happen to encounter an older girl, 18, 19, 20-year-old, who has HPV testing positive, you don't have to worry about that. There's enough strains in this vaccine that you still want to protect against those as well. All right. Now remember, 1/4 of all people will become infected by the cancerous high-risk strains. You heard earlier, 80% of all people get HPV strains, but 1/4 are going to get a potentially oncogenic high-risk strain. Most of these folks will clear, but not all, as we find out. And again, this HPV strains are very infectious and spreadable, and that last on the mucosal surface for up to 2 years. Infection before 17 means you have a 4 times higher risk of bad precancers, and actually a 6 times higher risk for cancers. So the younger you get this infection, the more likely you're to have major troubles later on. Well, everybody says, well, not my angel. I'm not going to give it to her until she's 15 or 17 or 18 or 19. I don't have to worry about her. Well, what has been found by Dr. Weiner in Seattle is that half of initially virginal college students will develop the HPV infection over 3 years, just the same rate as a sexually active high school girl. So you cannot spare the young ladies this infection. It's still going to occur as they age from almost all girls. Now, what about these rates of HPV infection, HPV vaccine? So what we do in our office, we use vaccines as a vital sign. So every time a nurse goes in for a sick visit or well visit, we look at the charts and ask about vaccines. If you're not up to date and you're not very sick, or you're at a checkup, we go ahead and give the vaccine to them if we can. The RN says, we would like to give you needed vaccines today. Any questions? It's not, would you like to get the vaccine? Do you know about the vaccine? It's, we need to give you this vaccine. We want you to give it. And the doctor comes in and reinforces it if there's any resistance or any questions. We say, you need this vaccine to prevent some very wicked and terrible cancers. This is a pre-cancer cancer vaccine prevention. And that's what we're after. We're trying to, and it's in the VIS forms as such. Safety is not a scientific issue. It is an anecdotal issue, mostly on the internet. So you need to know some data. First of all, about half of kids will get a sore arm, a local reaction, some headaches, and rare syncope. Syncope can be prevented. We did not see it in the clinical trials because they all remain sitting for 30 minutes after they got the vaccine. What happens in real life, in your office, you get the vaccine, they pop up, and within 15 minutes, they're passing out on you because of that vasovagal reaction is common among teens and preteens. So you need to make them all sit for 15 minutes so you don't have to deal with it. There have been lawsuits, and in fact, I've been asked to talk about this in a lawsuit, of the fractured nose, subdurals, etc. So you don't want to get involved with this. Make certain to sit in your office for 15 minutes afterwards. Remember, there's only 1 in 100 get a more painful local reaction. These are manageable. They're not serious. They are severe. They hurt better. And you need to know 3 safety articles. So I suggest you look at the abstracts from these articles. The first is HPV-4, the one I published in 2010. There's one HPV-9 just published in Pediatrics 2016. And then there's another one that's published on all the post-licensure data. These first 2 are clinical trial data, about 23,000 patients and 15,000 patients, and this one's, over 1 million patients or so. But again, this is 10 years of all the world's data in millions of patients that we just published for you recently in Pediatric Infectious Disease Journal. You also need to understand background rates of other diseases in teens. So it's really important to know the background rates. A patient say, on the internet, I read that. And you got to say, this is background information that commonly occurs in this age group. But the summary, lifetime effectiveness is important. So I've often framed this vaccine that the HPV NAB will reduce the rate of surgical, cervical, vaginal, vulvar treated precancers from 1 in 20 to 1 in 100. Thus, 1 girl in every classroom without the vaccine is going to develop a bad precancer. With the vaccine, you're going to get 1 girl in every 3 classrooms as a victim, something they can tangibly look at and say, oh, I understand that number. Also, the same thing occurs for venereal condyloma or venereal warts. It goes from 1 in 10 of all girls and boys goes to 1 in 100 with the vaccine. So this is huge. And again, for the boys, your son will unlikely become an unwitting participant in a girl's demise or surgery. They're spreaders. They may not get as much bad disease, except for oral cancers later, but they're spreaders to all these girls for these cervical precancers. All right, and if you don't believe in the devastation of HPV cancers, visit one of my oncology RN nurses at their work. This is devastating, and you've heard from Dr. Ramandetta that this is bad stuff. And again, even those that are taking great care and getting past her still get these bad precancers and cancers. And finally, you just gave your child the Menactor vaccine. Menactor vaccine's uptake is about 95% in most places. Ours is actually about 100%. And you didn't think twice about giving. It's a great vaccine. And this vaccine is, remember, MCV4, not MCV-B and MCV4. So with the quadrivalent vaccine, it prevents 75 deaths, 75 bad outcomes, 500 absolutely terrifying cases a year. Horrible illness. Prevention requires 2 shots. 1 cc total. I'm preventing some really bad cases. On the other hand, with HPV NAT, I can prevent 28,000 cases of cancer, 9,500 deaths, 250,000 cases of terrible, terrifying surgeries, 500,000 abnormal paps and biopsies a year, and over 1 million cases of venereal warts a year. Why isn't this up to 95% or 100% as well? I don't know. I try my best. And all this just for 1.5 cc's or 3 shots. The old adage, an ounce of prevention is worth a ton of cure applied. And someday we might get down to 2 shots, but that data is in the FDA dockets, and we'll see if that comes true. And you may need to explain internet gossip and background rates. This is what I encounter the most frequently. They're all worried about safety. I read on the internet that, or my friend said that this child or this daughter had this happen to them. The other thing that's out there from some quote-unquote experts across the USA, physicians included, that there's the aluminum toxicity from this vaccine. It is meaningless. There's no data to confirm that. And compared to the prevention of real and common cancers and precancers, this is a meaningless theory that should be abandoned. With that, I thank you.
Thank you, Dr. Block. As a reminder for all participants, you can submit your questions using the control panel of the webinar interface. So now we will hear from Anna Dragsbeck, President and CEO of the Immunization Partnership. Anna will be discussing laws, policies, and the HPV vaccine. Anna, the screen is yours.
Great. Thank you so much, Kanisha. And I just want to say how much I admire both Dr. Block and Dr. Ramandetta. They're really leaders in this field, and I'm really thrilled to be here today speaking with them. So I'm going to take a little different approach to this issue. I am a public health attorney. I have not taken a science class in several decades, so I leave the science to the scientists, but I can speak to you about laws and policies and the HPV vaccine. So I'm going to talk to you today about 3 different layers, if you will, of policies. First, you have your very local, very hyper-local clinic policies that you might implement in your own clinic. So these are the things that, you know, they don't do widely or many other places, or they might, but it is a particular policy in your clinic. The next level up is the enterprise policies. So if you work for a multi-practice group, you might have different policies and different ways of doing things that everybody has to do the same way. And then the last kind of overarching type of policy is the legislative policies. And those are the laws and other policies that take effect on like a statewide level that can impact your practice. So we're going to talk about each one of these layers and what can be done and also what cannot be done in each of these layers. So I'm going to start with legislative policies, the most broad, overarching type of policy that there is. And I want to start here because as a public health attorney and as someone who advocates for vaccines every day, I always get asked this question about the HPV vaccine. Why can't we just mandate it? If we just passed a law and everybody had to get it, then that would fix the problem. And as a public health attorney, I would love to be able to say, yes, you're right, all we need is a law. I can do that. But in fact, we have found that policies and laws do not actually solve the problem. And here you have a map of the various types of laws and policies, ranging from no laws up to school mandates, and everything in between of what has been tried in different states at different times. And what I would like to show you on the next slide is that HPV laws and policies may have a small correlation to elevated rates, but it's not consistent across the board. So on the left-hand side of your screen, you can see these are states that have the highest rates of HPV uptake. And the ones with the asterisk are the ones that have some kind of law or policy. So you can see 3 of the 5 states with the highest rates of HPV have some kind of law or policy, whether it's education or a mandate or some combination of the 2. But there are 2 states, New Hampshire and Vermont, that don't have any law or policy and have a pretty comparable high rate. And then you look on the other side of the screen and you can see the states with the lowest rates of HPV. Well, all but 4 have no kind of law or policy about the HPV vaccine. But what about Utah? They do have some kind of a law or policy regarding HPV, and they still have a very low rate. So as much as I would be able to like to say that the law is the key and all we need is to pass a bunch of laws, I can't say that with full confidence because really the jury's still out. And I think there's something else at play about the HPV vaccine that makes it particularly resistant to laws and policies that might be helpful with other vaccines to raise the rate. It just doesn't apply as neatly with HPV. There is some loose correlation, but not enough for us to say that, yes, that's the bullet cure. And here is a very interesting graph that I wanted to show you as well. Now, this is in the District of Columbia, where they actually do have an HPV mandate. It is required for school entry. It was required back in 2009. So you can see from 2008 to 2009, the rate actually did go up a little bit. So we're looking at the blue bar here. And then it kind of fell off. And it didn't come back up until 2014. The other thing I want you to note is that the light green and the dark green are Tdap and meningococcal, which are both vaccines that are given around the same age or at the same age as the HPV should be started. And the rates of those in Washington have risen very steadily, and in 2014 we were pretty high, actually within the Healthy People 2020 goals. Now, the HPV vaccine was also required along with these two vaccines, and so if it were going to have a similar effect, if the law was going to have a similar effect on HPV, we would have seen a comparable rise in the HPV rate across the board. But instead, we saw actually a little bit of a downward trend for the HPV vaccine. That also is an indicator that there's something else at work with the HPV vaccine, and mandates are probably not the whole answer. So I'll just leave you to think about that, and then I will also add that HPV has a long and sordid history in, it started in Texas, I'm sorry to say, and it's been politicized, and Governor Perry did mandate the vaccine for Texas girls entering, I believe it was 6th grade back in 2005, actually 2007, and that had a very bad response. And I believe it got national attention. Many of you probably remember that episode. It was actually repealed by the Texas legislature, and we had a prohibition on the books for several years against an HPV mandate. And even today, with the work we're doing legislatively with HPV, all of it is with the caution that Texas will never have a mandate because it just became so politicized. Now, I tend to believe that Governor Perry was doing the very best he could for all of the right reasons. I believe that he went about it the wrong way, and I think it turned into another episode of an unfortunate story in his past. This issue was taken up again in politics during the last election cycle, not this one, but the last one, and it got politicized even more. And so this is the way that a vaccine gets a lot of negative attention and actually spreads a lot of misinformation. And you can see the quote from the quote here. There's a woman who came up crying to me after the debate. She said that her daughter was given that vaccine. She told me her daughter suffered mental retardation as a result. There are very dangerous consequences. And we as public health professionals and scientists know that it's not possible. It's simply not possible that a daughter suffered mental retardation as a result of the HPV vaccine. However, this stuff gets out there and it's said by otherwise credible politicians that a lot of people take seriously, and it causes irreparable harm in the public's psyche around this issue. So there is one legislative change that I do think might have an impact. This is something they tried in California a few years back, but not many other states have tried it. I think it's worth a try. I do get calls on a regular basis from doctors whose patients are under the age of consent, so they're a minor, they're usually under the age of 18, and they confide in the doctor that they really think that they should have the HPV vaccine because they're sexually active and their parents don't know it. The parents have refused the vaccine on the minor's behalf, and so the doctor wants to know if they can administer it without parental consent. And in Texas, the answer is no, because you cannot administer a vaccine. The statute is very clear. You cannot administer a vaccine to a minor without parental consent. And in many states, if you are familiar with the laws of minor consent in your state, which many of you physicians probably are, many times a minor has the ability under the state law to consent to the treatment of an STD, but they don't have permission to consent to the prevention of an STD. So I'm just going to put that out there for you physicians and other community stakeholders who are active with your legislature. This is an area that I think is worth a try. If we allow minors to consent to their own HPV vaccine, it would make it much easier, for instance, to do a school-based immunization campaign where you don't need the consent of the parent. You can administer it right at school. It would be easier to keep them all up to date, and it could avoid a lot of difficult conversations with the parents that, as we know, are not always easy. So unproven but worth a try. Okay, the next thing I want to talk about is enterprise policies. So if you work in a multi-clinic practice, you probably have rules about a lot of things. And HPV should be one of the things that you have a rule about. It should be something that the whole multi-clinic practice agrees on. There should be policies put in place, and actually I think this could be one of the most efficient ways of raising immunization rates, that the provider recommendations should be the same. No matter what doctor you see that day, they should be saying the same thing. And what they should be saying is that your child needs the HPV vaccine, the Tdap vaccine, and the meningococcal vaccine in adolescence. Do you have any questions? So the recommendation, just as Dr. Block was mentioning earlier, should be made the same way on the same day. You don't say to them, your child needs meningitis and Tdap, and we could give the HPV vaccine if you'd like it, because that means that in your mind, the HPV vaccine is optional, and the patient's going to hear that and consider it an optional vaccine as well. So as a provider, you should be recommending it the same way, the same day, every time. And that can be an enterprise policy. That's something that you all can get together on and say, okay, as this 40 clinic enterprise that we are in, we are all going to band together and have this policy that this is how we approach the HPV vaccine. Another policy that I have found to be very effective is accountability. Publishing the rates, not just the HPV vaccine rates, but the rates for all vaccines for each individual doctor in the clinic, because let's face it, we all like to be publicly recognized when we're doing a job well, and those things that we measure usually increase or usually can be impacted. Incentives is another great policy that you could have at your enterprise level. So this can sometimes be in the form of insurance reimbursements. It could be in the form of bonuses from your enterprise. There are certain benchmarks where if a physician reaches them, they get some sort of incentive. Another thing that I also recommend is that there's consistent use at the enterprise level of declination forms. Many pediatricians know that they need to use the AAP declination form if a parent is declining a vaccine. Not too many of them use it for HPV. And as a risk management strategy, you should be using the same declination form for HPV as you do for MMR or any other vaccine. You need to document it the very same way, because it could come back and bite you later on in some kind of a malpractice suit. So then we come to clinic policies, and I want to rush along because I know we need to leave some time for questions. But this is really, I think, very, very basic and is probably the most accessible for everyone to implement right away, and that is your clinic policy. So even if you belong to an enterprise, you can still have your clinic policies. You need to sing from the same song sheet, so the whole clinic, as Dr. Remendetta was mentioning earlier, needs to be trained, from the front office staff to the person who checks you out at the end. Every person that is touched by that client along the way needs to have the same message. This clinic believes in the HPV vaccine. We immunize on time every time. We immunize at every visit. We believe collectively that this is a really important thing to do. You should implement standard procedures. For instance, every time an 11-year-old comes in for their shots, we start the series. This is the order, this is the protocol in our clinic. We don't wait until 13. We start them at 11. And then use reminder recall systems. I know they can be really burdensome, but it is proven to elevate the rate of HPV completion. And then, of course, immunize at every visit, just as the other physicians have mentioned, that you don't have to wait for a well child if they're not very sick. You can go ahead and immunize that day when you get them in your office. I think the real solution to HPV uptake is changing hearts and minds. And that's where the biggest challenge comes. We can't legislate people's opinion, and we can't legislate around people's preconceived notions of vaccine safety. So we need to be moving from this attitude that HPV somehow is connected to promiscuity to this message, which is basically that HPV prevents cancer. And that is the message that I suggest that you walk away from this webinar with. And, you know, you all have your own circles of influence, not just your patients, but you have friends, neighbors, your children's classmates, and they are looking to you for your opinion and guidance on this issue. And if we can all agree that HPV prevents cancer, I do believe that we can change the hearts and minds. And that's it.
Great. Thank you so much. I would like to thank Anna, Dr. Block, and Dr. Remendetta for your 3 very insightful presentations. We've been receiving some great questions while you've been presenting, so for the sake of time, I'm going to jump right in. I'll actually start with you, Anna. What are the downsides to minor consent? And also, do you foresee any major backlash from parents, and how do you advise educating parents if more states were to move forward with this as an option?
So, I mean, of course, there's a backlash. There's a downside to minor consent. You know, one of the things that you have to think about is if a minor can consent, can a minor decline? And that's going to depend on how the statute is written, so that even if the parent wants the child to get it, the child has the ability to say no. So that's one drawback of minor consent. I mean, it does cause a lot of conversations. It can, in California, they had a real uproar from the anti-vaccine community that this was not a decision that minors should be able to make. So, you know, there are some downsides to it. What was the second part of the question? How the education? How would you handle the education?
Yes. How would you?
Yeah, so I mean, I think, you know, education is basically a black hole. I mean, there is so much that you can do, and it all depends on what kind of a budget you have to throw at it. Of course, there's big mass media campaigns that can happen. You know, of course, the doctor and the nurse and any other providers in the clinic can be a part of the education process. If the child is getting this without the parent's consent, the parents may not need to know. It may be safer for the teen in some instances for the parent not to know. So I think there's a wide variety, and that's probably enough to fill up another whole webinar. So I'll leave it at that.
Okay, thank you so much for that. Also, Dr. Block, here's a question for you. How do you pitch the HPV vaccine to the parents of a young heterosexual male who isn't sexually active?
Okay, basically I tell them there's 3 main tenets to it. First thing is, we know that your child's going to be sexually active eventually in the future. Number 2, we know that 80% of all kids are going to wind up with an HPV strain, and 25% are going to wind up with a high-risk HPV strain. So for boys with the vaccine, we're going to prevent what? We're going to prevent 3 cancers probably. We know anal, we probably know oral, and we know penile cancers, of which oral cancers are skyrocketing, as you heard earlier. The second thing is preventing venereal warts. 1 out of 10 of these boys are going to wind up with venereal warts, and they're not pleasant, they're not very pretty, and they hate it. And we can go from 1 in 10 boys to 1 in 100 boys with venereal warts. And thirdly, they are not a spreader. They're not the ultimate unwitting participant in the demise of some young lady, their spouse, their girlfriend, etc. So they're not giving them cancer, and they're not causing them to die from a cancer. So those are the big 3 arguments I use for boys.
Okay, thank you. Dr. Remendetta, how about you take this one? Is there any connection between lung cancer and HPV?
Not that we're aware of. I mean, there are really 6 cancers to be aware of, as we've mentioned: vulvar, vaginal, anal, oropharyngeal, which specifically means tonsils and back of the tongue, cervix, and penile. We are not aware of any other connections related to HPV.
Okay, thank you for that. And then, and I'm moving through quickly for the sake of time. So back to Anna. Do you know if and where Spanish language declination forms are available?
I believe that they are available on the AAP website, but I can do some checking and send the link to Kanisha and make sure that everybody gets that.
Okay, and then finally, Dr. Block, is it advisable to, I think this is more of a clarification question, is it advisable to give the 3 doses for the HPV vaccine at one time?
I think they're talking about giving the Tdap, the Menactra or Menbeo, and the HPV vaccine. And yes, it is advisable at age 11 or 12. Whenever you catch them for that 5th or 6th grade physical, we do all 3 at once. That way you've got them all in there. Now, occasionally they don't like to give all 3 at once. And so I do a sneaky trick on this one. I'd kind of say, well, we'll give 2 out of 3 today. Is that okay? And most of them will go with 2 out of 3. So, okay, so we're going to give the meningitis vaccine and the HPV vaccine, and you can come back in a month to get the Tdap. And every state is required by subsequently, they got to come back. And then if I say come back in 2 months, they can get their second HPV and their Tdap. So it works real well to do that. If you got to go to the two vaccine max policy, that's the way to get around that issue. And one more thing on declination forms. A huge issue in practice, it's almost impractical to do. 35 to 40% of most practices get refusals. That's a huge volume. So I've taken the tact I've put in my charts. I have discussed with the family the risk of death, cancer, chemotherapy, and surgery without the vaccine. That's what I put in. I just put a 1-sentence line in there. And when I say that, I'm going to put this in the chart. This guy, I have to document for the lawyer's purposes. They go, oh, you are serious about this. Yeah, I got to put that in the chart just to protect myself. So that's one way around that declination form that I've explained to you. I've told you these things, and they go, oh, okay, well, maybe I should do it.
Okay, we've had one more question come in. Dr. Ramondetta, what is the fastest growing HPV-induced cancer?
It is oropharyngeal cancer, and this is occurring in men. And these are men. The average age for cervical cancer patients is around mid-40s, but can occur in the 20s all the way up till older age. In men, oropharyngeal cancer, average age is in the mid-50s. That's true for women too, but the majority of time these cancers are occurring in men, and anal cancers occur equally, usually in their 60s.
Okay, thank you so much. So our time really has come to a close here. I would like to thank you all for attending today's webinar, Opportunities to Increase Vaccine Compliance in the U.S., HPV and its Link to Cancer. As a reminder, I am Kanisha Baldwin, Director of Educational Campaigns at the Prevent Cancer Foundation. I encourage you to visit www.preventcancer.org. Think about the link for more information on our local outreach events that are part of our campaign. If you live or work in one of our targeted states and want to get involved, please email me at kbaldwin@preventcancer.org. My information should also have been included in your registration form for this webinar. Also, to learn more about how you can be an advocate for this campaign, please visit the advocacy section of our website. The link is now showing on your screen. Also, once you leave today's webinar, you will receive a survey on the presentations today. We greatly appreciate your feedback because we will be hosting additional webinars for this campaign and would love to have your participation. You will also receive a follow-up email within 48 hours with a link to view a recording of today's webinar, and we will also place it on our website. I'd like to thank our campaign sponsors, Merck, Gilead, and AbbVie, for their support of Think About the Link. Also, on behalf of the Prevent Cancer Foundation and our presenters today, thank you all for joining today, and we hope that you have a great afternoon. Thank you.